Management of narrow QRS tachycardia in children. Non-pharmacologic if pulseless CPR for pulseless electrical activity, PEA. If unstable with a pulse, cardioversion. Stable, vagal maneuvers. Surgical ablation, pacemaker. Pharmacologic adenosine beta blockers, BB, or calcium channel blockers, CCB. Amiodarone, digoxin. Management of myocarditis in a 16-yo. Diuretics, digoxin, inotropy. Afterload reduction, nitoproside, Milrin IV gamma globulins. Plecanaril, viral. Steroids, controversial. ED surgical, heart transplant, HTX, left ventricular assist device, assess, troponin, NT-proBNP, echocardiogram. Adolescent with hypertension, management. Lifestyle changes for managing hypertension for all patients with SBP 120 millimeters Grang or DBP 80 millimeters Herten. Identify indications for antihypertensive treatment. Select first-line antihypertensive medication based on individual patient characteristics. Titrate treatment to reach target blood pressure. Most adults, blood pressure 130/80 millimeters or grams. Individualized targets based on age and comorbidities. Follow up regularly, reassess indications for pharmacological treatment, and tailor therapy to individual needs. First-line medications for primary hypertension are thiazide diuretics, ACEs, ARBs, and dihydropyridine CCBs. Prevention of infective endocarditis considers risk factors: poor dental status, dental procedures, non-sterile venous injections, intravascular device, surgery, valvular disease, prosthetic valves, congenital heart defects. After surgery, if residual issues left, diagnostic and management of children with COVID-19 associated pediatric inflammatory multisystem syndrome, MISC PIMS principles, pediatric age, persistent fever, 3 days, laboratory markers of inflammation, signs or symptoms of organ dysfunction, lack of an alternative diagnosis, temporal relation to COVID-19 infection exposure. PIMS according to WHO, 0-19-yo, fever 3 days and 2 of the following: rash, hypotension or shock, proBNP, D-dimers, and elevated markers of inflammation. No other microbial cause of inflammation, evidence of COVID-19. Treatment: first line, IVIG plus methylprednisolone or either alone. Intensification therapy is recommended for children with refractory MISC who do not improve within 24 hours of receiving initial immunomodulatory therapy. Anakinra, methylprednisolone. Infliximab, low-dose aspirin 3 to 5 milligrams per kilogram once daily. Anticoagulation for patients who fall under one of the following clinical scenarios: therapeutic anticoagulation for patients with large CAAs. Therapeutic anticoagulation for patients with moderate to severe LV dysfunction who have no risk factors for bleeding. nephrotic syndrome, management, edema control, salt restriction, elevation of the legs or torso, loop diuretics, 25% albumin, loop, hypercoagulable state, prophylactic OAC, especially in hospitalized and severe patients. As 80% of PTS are steroid sensitive, a trial of prednisolone will biopsy is indicated. 2 mg kilo per day for 6 weeks, 1.5 mg kilo once every other day for 6 weeks. Biopsy is indicated if no response is obtained by 4 weeks. Relapses are treated with shorter higher dose GCS. Recurrency may require immunomodulation therapy. FSGS, only 30% respond to GCS psych or tacrolimus. ACE membranous nephropathy, poor response to GCS. ACE-I cyclophosphamide. An infant with the first urinary tract infection management, suprapubic aspiration for definitive treatment, blood culture, SP in neonates. USG to assess anatomy, voiding cystourethropy if needed. Cystitis bacteriuria, nitroamoxy. Pyelonephritis, ceftriaxone, cefazolin macrolides, fluoroquinolones. Neonates and ill toxic appearing infants, IV first. Antipyretics, fluid. If 2 days with no improvement, assess renal abscess and other causes. As per sepsis may be needed. How do we treat sideropenic anemia in children? Caused by dietary insufficiency, cow's milk protein intolerance, chronic inflammatory disease, chronic blood loss, menstruation. In an otherwise healthy child, a therapeutic trial of oral iron is the best diagnostic study for iron deficiency, as long as the child is re-examined and a response is documented. The usual therapeutic dose of 3 to 6 milligrams per day. The response to oral iron includes rapid subjective improvement, especially in neurologic function, within 24 to 48 hours, reticulocytosis 48 to 72 hours, increase in hemoglobin levels for 30 days, and repletion of iron stores 1 to 3 months. Other considerations: formula-fed toddlers increase other food intake, SP those with iron or iron supplemented formula, and limit milk intake. Severe iron deficiency, IV iron transfusion, RBC transfusion. The management of a child with vasovagal syncope. Avoid triggers, prolonged standing, emotional stress, pain, injury, heat exposure, non-pharmacological, increase fluid and intake, change, discontinue, or reduce the dose of diuretics and or antihypertensives. Patient education. Avoid triggers. Lie down when short prodrome. Physical counterpressure and water ingestion for long prodrome. First aid for FAM. Compression stockings for orthostatic syncope. Pharmacological. Midodrine, fludrocortisone. Here's the typed out information from the image in table format with bold emphasis. Question, outcome, considerations. Is it cardiac? Is it cardiac? PMA text of cardiac conditions or family history. Brugada. Brugada, arrhythmias. Q chest pain or palpitations. Occurs a normal cardiac exam, murmurs, and normal ECG, no. Is it a seizure? Lock forced ICCTIL, no. No. Did it happen on change of position or prolonged standing? Orthopsychological. Conversion disorder, Munchausen or malingering. Somatization disorder and hyperventilation. Vasovagal syncope. How do we treat the most common congenital hemolytic anemia in a child, that being spherocytosis in Poland? Autosomal dominant, RBC membrane protein defects, mild is asymptomatic, severe can present even in utero. Moderate usually presents in infancy or childhood. Treatment depends on severity. Non-surgical, phototherapy in neonates to prevent kernicterus, exchange transfusions in neonates, blood transfusions in case of a plastic or hemolytic crisis, folic acid supplementation to maintain erythropoiesis. Surgical, splenectomy, sole definitive treatment. Except in AR variant, children who are candidates for splenectomy include those with severe HS requiring RBC transfusions, those with moderate HS who manifest growth failure, other signs and symptoms of anemia. Splenectomy for children with HS should not be performed until the child is older than 6 years to reduce the risk of infections with encapsulated bacteria. Prior to procedure, vaccinate against S. pneumo, H. influenza type B, N. meningitis. Mortality is 200x greater. How do we treat physiologic anemia in an infant? Typically appears in term infants at 8 to 12 wool or 4 to 8 weeks in preterm. Term infants, typically at 8 to 12 wool. Asymptomatic, typically well tolerated, no treatment necessary. Preterm infants, typically at 4 to 8 wool. Pallor, apnea, lethargy, poor feeding. Treatment indicated if HB7 grel. Iron supplementation. Blood transfusion in symptomatic patients with low RBCs. How do we treat Schönlein-Henoch purpura? Mostly supportive, as it's self-limited. Fluid resuscitation, paracetamol for arthralgia or mild abdominal pain. May require hospitalization in severe cases, indicated if insufficient PO intake, extensive renal involvement, significant GI bleeding. If kidney involvement is severe, may require IV GCS, dialysis, or even kidney transplant. Requires follow-up so that renal involvement can be assessed. Use NSAIDs with caution as they may exacerbate renal disease or avoid completely if possible. Systemic glucocorticosteroids may be given in severe renal or GI involvement, but this is controversial. Oral prednisone or IV methylprednisolone. If you suspect this was induced by a drug, discontinue the drug. If lesions turn ulcerative, appropriate wound dressing is required. Systemic glucocorticoids. Indications: IJV nephritis, severe abdominal pain, rectal bleeding, orchitis, cerebral vasculitis, pulmonary, other features of severe vasculitis. Agents: mild to moderate disease, PO prednisone off-label, severe disease, methylprednisolone off-label. How do we treat a child with hemophilia? Early, appropriate replacement therapy is the hallmark of excellent hemophilia care. Early institution of factor replacement and continuous prophylaxis beginning in early childhood is likely to reduce the chronic joint disease associated with hemophilia. Bleeding associated with surgery, trauma, or dental extraction often can be anticipated, and excessive bleeding can be prevented with appropriate replacement and antifibrinolytic therapies. Prophylactic therapy, starting in infancy, has greatly diminished the likelihood of chronic arthropathy in children with hemophilia. To manage life-threatening bleeding, levels of 80 to 100% of normal factor 8 or factor 9 are necessary. For mild to moderate bleeding episodes, hemarthrosis, a Haas-Straw 40% level for factor 8 or a 30 to 40% level for factor 9 is appropriate. When adequate hemostatic levels can be attained, desmopressin is the treatment of choice for individuals with mild and moderate hemophilia A. Aminocaproic acid is an inhibitor of fibrinolysis with systemic and topical in the liquid form activity that may be useful for oral nasal mucosal bleeding. Substitution of clotting factors. I. Mild or moderate when needed, e.g. trauma, surgery. I. Severe hemophilia, prophylactically. EI recombinant factor 8, 8-tech. HB. Factor 8 dose, desired level sent, x weight, H.5. V. Factor IX dose, desired levels x weight 1.5. VI desmopressin acetate for mild hemophilia A. Vine emicizumab for hemophilia A. Discuss the management of pneumonia in a 4-year-old child. Page 519. This patient, preschool aged, most likely has a viral infection, less commonly but possible. S. pneumoniae, H. influenza, I. mild to moderate infections, home treatments with antipyretics, proper hydration and other supportive therapies as needs, antitussive, anticongestant, etc. Moderate to severe infections or moderate infections with RF, rapid antigen and or PCR testing with ready kits for the most common pathogen. A. RSV, B. parainfluenza, C. influenza, amantadine not recommended XX neuraminidase inhibitors, oseltamivir, peramivir, zanamivir, cap-dependent endonuclease inhibitor, baloxavir marboxyl. D. Antibiotics and bacterial. If being admitted to hospital, blood studies and CXR, I. CBC, I. EIP, procalcitonin, V. Blood culture, no sputum samples routinely. Supportive therapy as needed, I. respiratory support, E. antipyretics, admission criteria in children, hypoxemia 90%, E. signs of respiratory distress, E. suspected bacterial pneumonia in infants 6 meter, E. suspected pathogen with increased virulence, e.g. MRSA, V. poor adherence of caregivers, V. underlying conditions that may affect illness severity. If treated in outpatient department, arrange follow-up in 48 to 72 hours. Typically oral antibiotics for 7 days in bacterial etiology. Recommend getting I. plenty of rest, enough fluids, cough medicine as needed. A child with a foreign body in the airways, management. Prioritize airway management and respiratory stabilization. Incomplete obstruction, attempt first aid. I. responsive child, initiate 5 back blows. If ineffective, proceed to chest thrusts, infants, or abdominal thrusts, children 1Y. E. unresponsive child, start CPR. Attempt laryngoscopy guided foreign body retrieval. If ineffective, emergency surgical airway, i.e. needle cricothyrotomy. Partial obstruction. I. responsive child, encourage coughing to dislodge body. Plan removal of it, broncholaryngoscopy. If patient can speak, cry, cough, do not attempt back blows as these maneuvers can risk dislodging FB and converting partial to complete obstruction. Take care with laryngobronchoscopies, even planned removal, as they risk turning partial to complete obstruction. If above fails, surgical management, thoracotomy with bronchotomy, or segmental resection to remove foreign body. A child with ketoacidosis management, fluid resuscitation, IV, crystalloids, 10-20 mg Valium over 1 to 2 hours, repeated when necessary. Potassium repletion. Before insulin, especially if hypo or low normokalemic. Insulin therapy, 0.5-0.1 unit kilogram per hour. Initiate short-acting insulin once K 3.3 the. Based on weight, Continue child's long-acting insulin if applicable. Glucose should be added to IV fluid when glucose is 200 to 300 to prevent hypoglycemia. Bicarbonate if pH 7.0. If in shock, start resuscitation, ABC. Monitor hourly blood glucose and ketones. Monitor electrolytes. Cerebral edema. Treatment involves the rapid use of IV mannitol, endotracheal intubation, and ventilation, and may require the use of a subdural bolt. A child with hypoglycemia management, in mild cases, oral glucose 10 to 20 grams, e.g., sugar packet, juice, candies, glucose tablet. If unconscious, unable to swallow, IV glucose 2 milliliters per kilogram, 10% dextrose. IM glucagon if unresponsive. After the initial bolus, an infusion of IV glucose should provide approximately 1.5 times the normal hepatic glucose production rate, 8 to 12 milligram kilograms per min in infants, just 6 to 8 milligrams per kilograms mins in children. IV. If adrenal insufficiency is suspected, stress doses of glucocorticoids should be administered. Monitor blood glucose levels closely to ensure they return to the normal range and remain stable. Depending on the severity and cause of hypoglycemia, further diagnostic tests may be necessary to evaluate for underlying medical conditions. Follow up with a healthcare provider or pediatric endocrinologist for ongoing management and monitoring, especially in cases of recurrent or persistent hypoglycemia. Find the etiology: excessive insulin administration in diabetic children, insulin overdose, adjust insulin dosage or regimen in diabetic children, delayed or missed meals or snacks. Provide regular and balanced meals and snacks to prevent hypoglycemia in children prone to low blood sugar. Assess for poverty or child abuse. Increased physical activity without adequate carbohydrate intake. Endocrine disorders such as congenital hyperinsulinism, adrenal insufficiency, or growth hormone deficiency. Liver disease, metabolic disorders, or certain medications. Management of a child with severe exacerbation of asthma, supplemental O2, bronchodilators, high-dose inhaled SABA albuterol, I plus high-dose inhaled SAM muscarinic antagonist, ipratropium bromide, early corticosteroids, oral prednisone, IV prednisolone, or methylprednisolone are okay if patient can't swallow. If no improvement within 1 hour of therapy, consider IV magnesium sulfate equals 25 to 75 mg, maximum 2.0 gram. Intramuscular epinephrine or subcutaneous terbutaline is rarely used except when severe asthma is associated with anaphylaxis or is unresponsive to continuous administration of SABAs. Find etiology if it's infectious. Treat accordingly. An 8-mo infant was given an egg for the first time in his life. 5 minutes after she developed massive hives, vomiting, and a brief loss of consciousness. Suggest management. Anaphylaxis, type 1 hypersensitivity reaction due to IgE-mediated mast cell activation. Stabilize patient. ABCDE. Provide O2 if needed. Remove egg, allergen, from surroundings. Administer epinephrine 0.01 milligrams per kilogram into anterolateral thigh. Administer IV fluids. Monitor in acute care for at least 4 to 8H. Continuous pulse and cardiac monitoring. If needed, extra doses of epi, inhaled epi or B2 agonist, GCS, glucagon, especially if taking BB. Prescribe and train parents on epinephrine injection. An unconscious teenager was brought to the ED management. Collect history from first responders, family, witnesses. ABC assessment. Reason for lack of consciousness. Treat that. Common causes in adolescence: drug alcohol overdose, hypoglycemia. Alcohol, epilepsy, heat stroke, hypothermia, hypoxia, uremia, trauma, infectioning, toxins. Stroke, unlikely in teen. Here's the typed out information from the image in table format with bold emphasis. Condition, diagnostic approach, management, confirmed by blood urinary analysis. Drug alcohol overdose, by exclusion and presentation, confirmed by blood urinary analysis. Replace Glu-Vit B6, B12, and others when necessary with cofactin, antidote as per drug. Rapid glucose testing, IV glucose, 2 mg 10% dextrose, then IM glucagon if needed. Epilepsy, by presentation and history, find etiology. Vitamin B1 thiamine, oxygen if needed. No IV or pre-hospital, IM, intranasal or buccal midazolam, buccal lorazepam, or rectal diazepam. In hospital, lorazepam, IV route, or midazolam, IV or IM route, are equally appropriate first-line options. Heat stroke, hypothermia, presentation history, PE and electrolytes analysis. Hypo IV fluids, blank or warming, bladder fluids, heat stroke, hydration, electrolytes, cooling hypoxia. O2 and an etiology. Provide O2 and ventilation if necessary. In bronchospasm, SABA, GCS may be needed. Trauma, history RFPE, USCT, obstruction risk, removal of body infections per pathogen and location, internal X bleeding, CNS, spine injury, shock, etc. A child with cervical node inflammation management. What other symptoms are there? Examine patients, take history. CBC with morphology. Most likely cervical lymphadenitis. Mild illness generally doesn't require treatment. If bilateral cervical lymphadenitis and exudative pharyngitis, test for gas. For severe illness, treatment based on etiology. I, EBV, supportive. I-CMV, valganciclovir in immunocompromised patients. Acute unilateral case, amoxicillin clavulinate, cephalexin, or clindamycin for 10 to 14D. Persistent inflammation and enlargement require further testing for more rare causes. Lyme, cancers, leukemia, lymphoma, extension of other tumors. Post-infectious persistent lymphadenopathy. Biopsy may be required as opposed to watchful waiting when the management of a child diagnosed with asthma. In children, 5Y. I, newly diagnosed asthma. Saba, newly diagnosed plus symptoms 3x a week. Or previous treatment ineffective. Sabas inhaled corticosteroids, budesonide, 200 milligrams. E Saba ICS leukotriene receptor antagonist. I Saba ICS plelabe. V Sabas maintenance and reliever therapy. Sabas ICS Mart. Vi Saba increase ICS to higher dose, 400 milligrams. In children 5Ys, I may require nebulizer rather than inhaler because they're unable to use one properly. D Saba plus 8-week trial period of ICS 200. Eve, Sabus ICS LTRA. V, stop LTRA, refer to asthma specialist. First step in both, Saba via nebulizer or meter dose inhaler, only as rescue inhaler as needed. ICS and LTRA as daily therapy. Saba remains rescue inhaler as needed. Assess response to therapy in 2 to 6Q. If good response for 3 consecutive months, consider going down a step in pharmacotherapy. If inadequate response, assess treatment adherence and inhaler technique. The management of a child with suspected pleuropneumonia, which is pneumonia complicated with pleurisy, involves several important steps. 1. Clinical assessment and diagnosis. Thorough history taking and physical examination. Consideration of symptoms like chest pain that worsens with breathing, fever, cough, and difficulty breathing. Auscultation may reveal decreased breath sounds and pleural rub. 2. Imaging. Chest x-ray to identify pneumonia and possible pleural effusion. Ultrasound or CT scan if there is difficulty in assessment or to evaluate the extent of pleural effusion. 3. Laboratory tests. Complete blood count, CBC, to check for elevated white blood cell count. blood cultures to identify causative bacteria, sputum culture if the patient can produce sputum, pleural fluid analysis if thoracentesis is performed. 4. Medication. Antibiotics to cover the likely pathogens, which may be adjusted based on culture results. Analgesics and antipyretics such as acetaminophen or ibuprofen to manage fever and pain. If pleural effusion is present and causing significant respiratory distress, thoracentesis may be required to remove fluid and relieve symptoms. 5. Supportive care. Oxygen therapy for hypoxemia. Hydration and nutrition support. Rest and monitoring in a hospital setting if the condition is severe. 6. Follow-up. Regular monitoring of the child's respiratory status and temperature. Follow-up imaging to assess response to treatment. Adjustment of antibiotics based on the clinical response and laboratory results. 7. Education and prevention. Educating the family about the importance of completing the entire course of antibiotics. Discussing preventive measures such as vaccination against common organisms causing pneumonia, like Streptococcus pneumonia and Haemophilus influenzae type B. 8. Complication management. In cases of large pleural effusions or empyema, chest tube placement may be necessary. Surgery, like a decortication procedure, might be needed for organized empyema or failure to respond to conservative treatment. Children with pleural pneumonia require close monitoring for potential complications and often require hospitalization, especially if younger than 2 years or if there are signs of severe illness. Management of a child with chronic rhinitis, allergic or non-allergic. Allergic, I advise patient to avoid exposure to triggering allergens, e.g. dust, animal dander. E. Mild allergic rhinitis, intranasal corticosteroids, budesonide. E. Moderate to severe, intranasal corticosteroids, with or without intranasal antihistamines. Daily administration is necessary for maximum effectiveness. IV oral or intranasal decongestant. V. Intranasal saline. VI. Allergen immunotherapy. Non-allergic. I. Unknown cause rather than drug-induced, mostly occur in middle-aged individuals, so rather not a child. T. Infectious. Topical ipratropium bromide, an anticholinergic nasal spray, is used primarily for non-allergic rhinitis and rhinitis associated with viral upper respiratory infection. Management of a child diagnosed with Down syndrome. Monitor growth. Evaluate, monitor, and treat associated symptoms. Cardiac. Echocardiograms, heart surgery for malformations, often associated with ASD. Also VSD, tetralogy of Fowlet, patent ductus arteriosus. GI, duodenal atresia, megacolon, anal atresia, Hirschsprung disease. Others, hypothyroidism, DM1, celiac, obstructive sleep apnea, hearing loss, increased risk of developing epilepsy. Hematological assessments, higher risk of AL and AML. Therapies, physical, behavioral, speech. Occupational. V, family education. Management of a child diagnosed with Down syndrome. Monitor growth. Evaluate, monitor, and treat associated symptoms. iCardiac. Echocardiograms, heart surgery for malformations, often associated with ASD. Also VSD, tetralogy of Fallot, patent ductus arteriosus. EGI, duodenal atresia, megacolon, anal atresia, Hirschsprung disease. Others, hypothyroidism, DM1, celiac, obstructive sleep apnea, hearing loss, increased risk of developing epilepsy. Hematological assessments, higher risk of AL and AML. Therapies, physical, behavioral, speech, occupational, V, family education. Treatment of a child with infectious impetigo, non-bullous impetigo, topical fusidic acid, topical 2% mupirocin, topical retapamulin 1%, or oral antistaphylococcal antibiotics. Extensive or disseminated lesions, bullous impetigo, lesions around the eyes, or lesions otherwise not amenable to topical therapy are best treated with oral antibiotics. Flucloxacillin or erythromycin. Streptococcal impetigo is associated with increased risk of post-infectious glomerulonephritis, but not acute rheumatic fever. Children with impetigo should remain out of school or daycare until 24 hours of antibiotic therapy have been completed. Treatment of pneumonia in a newborn, onset within hours of birth, generalized sepsis or after 7 days and confined to lungs. Mostly GBS, E. coli, S. pneumoniae, S. aureus, CMV, HSV, hemoinf, listeria, chlamydia. CXR pulse oximetry blood culture. Evaluate for sepsis. Supportive for symptoms plus O2. Antibiotics, ampicillin, cefotaxime, aminoglycoside plus antistaph. Start empiric antibiotics if sepsis suspected. Vancomycin, E, plus broad-spectrum beta-lactam, meropenem, piperacillin, tazobactam, cifepime. Adjust antibiotics after receiving results of culture. For chlamydia, erythromycin or azithromycin. Treatment of a child with infectious impetigo, non-bullous impetigo, topical fusidic acid, topical 2% mupirocin, topical retapamulin 1%, or oral antistaphylococcal antibiotics. Extensive or disseminated lesions, bullous impetigo, lesions around the eyes, or lesions otherwise not amenable to topical therapy are best treated with oral antibiotics, flucloxacillin or erythromycin. Streptococcal impetigo is associated with increased risk of post-infectious glomerulonephritis, but not acute rheumatic fever. Children with impetigo should remain out of school or daycare until 24 hours of antibiotic therapy have been completed. Management of a child diagnosed with primary herpes stomatitis. Usually self-limiting, resolves without complications. Ensure adequate hydration and analgesia. In immunocompromised children, administer cyclovir. I 10 milligrams per kilograms, max 400 milligrams, IV 8 hourly until no new lesions. Immunocompetent children don't usually need a cyclovir, but if the course is severe with severe pain and dehydration for over 72 Hu, can give 10 milligram kilogram PO5X a day until no new lesions. HSV encephalitis may be indicated by lethargy, drowsiness, focal neurology, altered behavior. If they have no control of oral secretions, drooling, thumb sucking, they should be excluded from childcare until non-infectious. (16 Mo child with strabismus, management. Eye patch occlusion over the good eye to encourage development of vision in the bad eye. Eye patch for 4 to 6 weeks. Duration depends on child's age, but it's crucial for a 16-month-old. If the child doesn't tolerate an eye patch, cyclopentolate atropine 0.5% can be given as eye drops, blurs vision, encourages the child to use the bad eye instead. Can only be treated in childhood, so explain to parents the importance of making sure the child adheres to treatment. Botulinum toxin therapy. Surgical option also available. Transposing or repositioning muscles, or tucking to tighten muscles, or myectomy to loosen muscles, depending on the type of strabismus. Management of a child with pneumothorax. Assess stability. Provide respiratory support. Treat dyspnea. Eye upright positioning. Supplemental oxygen. If the patient requires mechanical ventilation, insert an emergency chest tube. Evaluate type and size of pneumothorax. Immediate chest decompression in unstable or high-risk patients, tension or bilateral pneumothorax. Stable spontaneous pneumothorax. I when RR is normal, SpO2 on room air 90%, able to speak, normal HR, normal BP. T, low risk, conservative management. EI, high risk, chest tube placement. In the 4th-5th intercostal space at the mid-axillary line, always check with CXR to confirm correct placement. Small pneumothoraces, 20% of thorax occupied with pleural air, may not require intervention as they often resolve spontaneously. Inhaling high concentrations of supplemental O2 may enhance the reabsorption of pleural air by washing out nitrogen from the blood. Larger pneumothoraces and any tension pneumothorax require immediate drainage of the air, preferably via chest tube. In an emergency, a simple needle aspiration may suffice, although placement of a chest tube is often required for resolution. In patients with recurrent or persistent pneumothoraces, sclerosing the pleural surfaces to obliterate the pleural space, pleurodesis, may be necessary. by instilling talc or sclerosing agents, doxycycline through the chest tube, or mechanically by surgical abradement. Here's the information from the image with bold emphasis for readability. Approach 6. 8 all patients. Assess patient stability. See e.g. stability criteria for spontaneous pneumothorax. Provide respiratory support and treat dyspnea. Evaluate the type and size of pneumothorax. Unstable or high-risk patients, e.g. with tension pneumothorax, bilateral pneumothorax, or who require mechanical ventilation. Immediate chest decompression, treat obstructive shock if present. Stable spontaneous pneumothorax management depends on the risk of progression and recurrence. Low risk, conservative management. Higher risk, chest tube placement. Traumatic pneumothorax management. Most patients require chest tube placement. Follow the ABCDE approach to trauma to assess for additional injuries. Monitoring and disposition. Consider the following consults: pulmonology, stable spontaneous pneumothoraces, thoracic surgery, traumatic pneumothoraces, large secondary pneumothoraces, ICU, unstable patients or those with large secondary pneumothoraces. Regularly reassess patients for clinical features of deterioration, development or recurrence of a tension pneumothorax. See also disposition of patients with pneumothorax. Management of a child with atopic dermatitis. Daily lukewarm baths for 15 to 20 minutes, followed immediately by the application of fragrance-free emollients to retain moisture, are a major component of therapy. Prevention of xerosis is important for pruritus control and for maintaining the integrity of the epithelial barrier. Emollients should be ointments or creams. Lotions are not as effective because they contain water or alcohol and may have a drying effect owing to evaporation. A mild non-soap cleanser also is recommended. Maintenance therapy, very mild AD, non-pharmacologic therapy, e.g. emollients shortly after bathing. Mild to moderate. If above not sufficient, add pharmacologic, topical steroids, or topical calcineurin inhibitors. Moderate to severe, escalate non-pharmacologic, e.g. wet wrap therapy with emollients, increase potency of topical agents, consider adding systemic therapy, phototherapy, immunomodulators. Acute flares, topical pharmacotherapy, topical steroids or calcineurin inhibitor, optimized non-pharmacologic therapy, consider systemic therapy in severe cases. Also identify comorbidities, e.g. allergic rhinitis, asthma, food allergies. Avoid triggers as much as possible. Manage stress. A 3-year-old child with a respiratory tract infection received amoxicillin. 30 minutes after the first dose, urticaria appeared on the skin without any other symptoms. Management: likely to be penicillin allergy. Remove causative factor. Stop taking penicillin. Even if there are no other symptoms, you don't want to exacerbate them, as in some cases, it can lead to anaphylactic shock. Assess and monitor the patient to make sure their condition isn't deteriorating. Make parents aware of penicillin allergy to prevent it in the future. Rash should disappear within 24 hours of stopping amoxicillin. Refer patient in the future to test for true penicillin reaction test, as this may not be a penicillin allergy, e.g. associated with EBV instead, or the respiratory tract infection is associated with it instead, or other food allergy. Antihistamine to relieve hives and itching. Reevaluate the need for antibiotic in this respiratory tract infection. If needed, change to another non-penicillin antibiotic, e.g. cephalosporin.